Humbert and Rinki founded Dysphagia Grand Rounds this year. And to help bridge the gap, to help bridge the research practice gap in dysphagia management, and to help clinicians learn how to appraise and apply dysphagia research to their practice to help improve patient outcomes. And before I turn this over to Dr. Humbert, I have two quick polls to give them a feel for who's in our audience tonight. So if you would take just a minute to click yes or no. Are you certified in electrical stimulation? Okay. And 40% of you said yes, and 59% of you said no. And the second question, oh, this just is not. Here's the second question. Do you use electrical stimulation in your clinical practice? And about almost 80% of you have voted. So about a third of you do use it in your practice, and 2/3 do not. So thank you for participating in that poll. And at this time, I'd like to turn it over to Dr. Humbert for this evening's discussion.
All right. Hi, everybody. Hope you guys can see my screen well enough. Elizabeth, will you tell me if that looks great?
Right now, what we can see is the presenter mode.
Okay, let me just flip that over then.
Okay.
Better?
Yep, that looks fantastic.
Wonderful. Hi, everybody. I'm so excited that NFOSD has asked us to collaborate with them on this venture, and I'm going to jump right into the talk. So the question that we are asking is, to e-stim or not to e-stim? Is that the question? Hold on just a second. I need to do something here. Okay, so the article that we actually reviewed is Effects of Surface Electrical Stimulation, both at rest and during swallowing in chronic pharyngeal dysphagia. And in order for me to really get into this paper, I really need to take you all back to 2003. 2003 was the year that I started at the NIH as a lowly doctoral student in the laryngeal and speech section, and my dissertation advisor, who was Christy Ludlow, is basically somebody who's influenced me to be interested in electrical stimulation. So while I was brand new at the NIH, there is the company, I'm sure you all are familiar with, called Vital Stim Therapy, and the representatives came to the NIH to talk about whether or not we should be investigating this, and basically they wanted us to do a study on it. The beginning of the session looked a little bit like this picture you see on the left. By the end of the session, it looked a little bit more like that. And part of the reason why I'm going to get into, but I just want to explain to you that by the end of this meeting, this was my face. I was like, what just happened in that room? So let me just tell you what happened that took the meeting from this seemingly relatively calm situation to more of a science fight, I guess we could call it. as you probably know, manufacturers make things and they make claims, and that this is what this product is going to do. And when you bring those claims to scientists, it's basically our job to ask questions and decide if we accept or if we reject those claims. The issue in this particular meeting is that the claims were pretty much amplified, and unfortunately, they were sorely rejected. So let me talk about what some of those claims were. Here's a little background. One claim is that surface electrical stimulation on the anterior neck will lead to increased hyolaryngeal elevation. And so that study comes from a paper by Marcy Freed in 2001 and another paper by Leela Manet in 2002. And so I'm going to read the conclusions. The study supports the hypothesis that stimulating synchronous contraction of the thyrohyoid muscle by synchronous electrical stimulator during swallowing improves dysphagia resulting from reduced laryngeal elevation. Another claim was in the manual that we received when we did the training, indicating that most patients should elevation during the first session. Now, I'm going to jump right into the principles of surface electrical stimulation. In Dysphagia Grand Rounds, we have a much more expanded version of this talk, but given that I have 30 minutes, I'm going to jump right into the principles, and hopefully when I get you through these principles of electrical stimulation, then some alarm bells will be going off in your head as to why those claims may not be true, and some of the issues that led to the science fight, we'll call it. So I'm going to read this quote to you. When electrical stimulation is applied to the skin or oral mucosa at low current levels, it activates the sensory nerve endings in the surface layers, providing sensory feedback to the central nervous system. With increased current amplitude, the electric field may depolarize nerve endings in muscles lying beneath the skin surface and may spread with diminishing density to produce muscle contraction. Now, if this is your face right now, that's okay, because I promise you I'm going to explain it. And I'd like to take it back to my day in the 80s, and this is probably, if you remember different strokes, maybe you look like this. But I'm going to explain what I'm talking about, Willis. Okay, here we go. So, when electrical stimulation is applied to the skin or oral mucosa at low current levels, it activates the sensory nerve endings in the surface layers, providing sensory feedback to the central nervous system. So what does this mean? If we take a cross-section of a random part of the body, like the arm, as you can see, we will have skin, deeper, you'll have some sensory nerves, you'll have fat, you'll have muscle. Okay, so skin with the sensory nerves, fat, and then muscle. Now, if you put electrodes on the skin and you give it a little bit of boost, then you will basically send a current at a low level, if it's just a low amplitude, through just the sensory nerves of the skin, okay? And so that's what that first part of that paragraph means. The second part of the paragraph reads, with increased current amplitude, the electric field may depolarize nerve endings in muscles lying beneath the skin surface and may spread with diminishing density to produce muscle contraction. So if I increase the amplitude, then I'm going to have a deeper current, and I will depolarize not just the skin, but also the muscle, okay? And so the sensory nerves and the muscle contraction will occur, okay? You never get rid of the sensory nerves. You always just go deeper and get more sensory nerves, okay? So sensory nerves get more stimulation when muscles are getting less. Superficial tissues always get more stimulation than deeper tissues. That's just the nature of surface electrical stimulation. The electrodes are the source of the power, the stickers on the skin, so the most stimulation will occur closest to the stickers on the skin. So now, what this means is if you have muscle 1, 2, and 3, then you basically would have most stimulation on the skin, more on muscle 1, less on muscle 2, and the least on muscle 3. So stimulating multiple muscles, when you do that, the outcome is easier to predict when all of the muscles that are stimulated contract similarly. So what do I mean by that? Let's say muscle number 1, 2, and 3 are all aligned horizontally. If I apply stimulation to each of deeply to this muscle group, then we can expect that they will contract in a similar direction. What's an example in our body? Well, the quadriceps are a good example because stimulating the outcome is easier to predict in this case because each of these muscles are longitudinally aligned. So they will all shorten when contracted because all of the muscle fibers are aligned in a similar direction. The other good thing about stimulating the leg is if you want to oppose the quadriceps, you have to go to the back of the leg. So there's no risk that if you stimulate somewhere between the knee and the hip on the quadriceps that you're going to get an opposing muscle group because all of the muscles in the quadriceps have a similar function. You'd have to go around to the hamstrings in order to oppose the quadriceps. These principles are not true when it comes to the neck. So here's what I mean. The submental region right here is important for elevating and moving anteriorly the hyoid bone. But if you go just below that between the hyoid and the thyroid cartilage to get the thyrohyoid, it pulls the hyoid down and elevates the larynx. Now, if you put just one layer of muscle over those muscles, then what happens is you get the posterior digastrics, which pull the hyoid up and back. And then you now have the omohyoid and the sternohyoid, which pull the hyoid and the larynx down, and the sternothyroid as well. So in this very small region, we have all of these muscles that have different functions, and the likelihood that you're going to stimulate all of them is pretty high. Okay? Let me just move my mouse over here so I can see what I'm doing. Okay, so what does this mean? That the fact that they're all in the anterior neck? Well, stimulating multiple muscles in this case is difficult to predict the outcome. So muscle number 1 is aligned this way, muscle number 2 is aligned this way, and number 3 is aligned this way. When they contract at the same time, well, it's hard to know what will happen. So let me read you another quote to move this whole concept forward. When electrodes are placed in the submental region, therefore, the current density is greatest at the skin surface and diminishes with depth through the platysma underlying the skin and subcutaneous fat, and I'll show you what that looks like in the next slide. Accordingly, as the current is increased in amplitude, increasingly deeper muscles may be recruited, albeit with less efficiency. Such muscles include the anterior belly of the digastric, which can either lower the mandible or pull the hyoid up depending on whether the mouth is held closed. Deeper still are the mylohyoid and geniohyoid muscles, which pull the hyoid bone upward toward the mandible, respectively. These muscles are much less likely to be activated by surface stim, however, because of their greater depth. So, what is platysma? It is that very thin sheath of muscle that goes from just under your lip area all the way down to below your clavicle, and it's meant for these kind of facial expressions. So it's immediately below the skin. Then deep to the superficial, the platysma, are your extrinsic and your extrinsic laryngeal muscles. Okay. So to answer the question, are hyoid bone and laryngeal muscles similarly aligned? The answer is absolutely no. So, given that the sternohyoid muscle is larger and overlies the thyrohyoid and sternohyoid, we expect that high levels of surface electrical stimulation on the neck could pull the hyoid down because of stimulation either the sternohyoid or the underlying sternothyroid, but would be much less likely to raise the larynx toward the hyoid bone as occurs in normal swallowing. So while the manufacturers were claiming that you would get hyolaryngeal elevation, our hypothesis was the opposite, that you would actually get hyolaryngeal depression because of the way the muscles are aligned and because of the principles of surface electrical stimulation that I was telling you about. In other words, the muscles that are closest to the electrodes are muscles that pull the hyoid and larynx down. Now, deeper muscles are muscles that pull the hyoid and larynx up. So since the depressors are getting more stimulation, the likelihood that you're going to get elevation, we do not expect that would happen. Okay? Because you'd have to get through skin, fat, platysma, the sternohyoid, and the sternothyroid. Now, the target is the sternothyroid, but more superficial is the stimulation of the sternohyoid, which has the opposite effect. So now, hopefully, there are alarm bells ringing in your head. So our hypothesis is that Simultaneous transcutaneous stimulation with 2 pairs of electrodes at rest would cause 1, the hyoid bone to descend in the neck due to sternohyoid muscle action, 2, the hyoid bone to move posteriorly due to the omohyoid muscle activity, and 3, the larynx to descend if current activates either the sternohyoid or the sternothyroid muscles. We also hypothesized that in severe chronic pharyngeal dysphagia, when the same muscle, the electrode array, which I'll show you, is used at low levels of stimulation, so just the sensory level, the very low level that only stimulates the skin and not the muscles, that it would be sufficient without muscle activation, and swallowing might improve as a result of sensory facilitation. But at higher levels where you stimulate the muscle, that it would interfere with swallowing, and actually you get increased penetration and aspiration. So again, we're hypothesizing that sensory-only stimulation would facilitate swallowing and reduce aspiration, but deeper stimulation that activates the muscle because it pulls the hyoid and larynx down would actually interfere with swallowing and cause penetration or aspiration. So how did we test this? There were 11 patients with chronic pharyngeal dysphagia, and they were able to follow instructions because they had a decent mini-mental state examination score. They had a severely restricted diet, but they were medically stable, and they had a risk or definite aspiration on video fluoroscopy. So we used the vital stim device, and we used placement 3B, which has 2 electrodes above the hyoid bone and 2 electrodes across the thyroid cartilage across the larynx. So the one channel was sending current between the submental region, and the other was across the larynx. Now, we chose placement 3B because the manufacturers indicate that most laryngeal elevation would occur with placement 3B. However, as I said before, these are actually opposing musculature. Okay, so that's really important to understand. So after we place the electrodes in this array, we familiarized the patients with electrical stimulation, and we identified sensory level stimulation, just that very low level. And so again, just when do you first feel the prickly or tingly sensation? And we determined what that was for each person. And of course, we confirmed this with video fluoroscopy because when we turn the stimulation on, there should be no movement because we're not stimulating any muscles. We then identified the motor level stimulation, which is where there's a deeper sensation that actually causes a muscle contraction. And we called it a tugging or grabbing experience. And it's the highest that they could tolerate without pain. Again, we confirm movement with stimulation, with imaging, with video fluoroscopy. Then we tested stimulation at rest, and we tested stimulation during swallowing. So now, let's talk about how we tested stimulation at rest. If you're familiar with the vital stim device, stimulation is on for 59 seconds and off for 1 second. That's the way the device runs. So what we wanted to do is not have video fluoroscopy on for a whole minute if we really only wanted to see that period right here, which is our target observation period, where stimulation is on and off, so we can compare and contrast the difference between stim on and stim off. So what we did is when stimulation was ongoing, we started video fluoroscopy just a few seconds before the stim would go off, and we recorded any movement during just before the stim was off and just when the stim came back on. So that means that we got an on-off-on stimulation pattern within about 10 seconds. And what we hypothesize is that when stimulation was on, the hyoid and larynx would be low, and when stimulation is off, the hyoid and larynx would move back up, and then when stimulation came back on, the hyoid and larynx would be low again. Okay, now let's talk about how we tested stimulation during swallowing. Patients were given either 5 ml or 10 ml of thin liquid barium, and the goal was to determine the bowls with the highest risk of aspiration or definite aspiration. The tasks included swallowing with no stimulation, and swallowing with sensory stimulation, and swallowing with motor stimulation. And we had limited radiation exposure time, so we got about 1 to 3 trials of each. Now, our data analysis for movement to understand how the hyoid and larynx moved involved marking the hyoid bone, the subglottal air column, and we also marked the vertebrae, cervical vertebrae 2 and 4 as reference positions. To understand about the penetration aspiration severity, we use the penetration aspiration score, which I'm sure many of you are familiar with. But as you may already know, 1 and 2 are normal. 3 through 5 are penetration that is either above the vocal folds or below, and a question of whether or not it was ejected. And 6 through 8 is aspiration. And of course, if you have an 8, it means that you made no effort to eject the aspirate material. So we had a problem with the penetration aspiration scale, and here's what it was. We found that patients with severe dysphagia who had a PEG because of severe dysphagia would get a penetration aspiration score of 1. And what we often saw is that these were people who had no UES opening and were experts at regurgitating the bolus right back into their mouth without aspiration. So they go to swallow, the bolus would go nowhere, and they would just regurgitate it right back out of their mouth. Now, obviously that's not normal, but because the penetration aspiration score only looks at aspiration or penetration, it didn't pick up any issue, that there was any problem. So we derived the NIH swallowing safety scale, and I'm going to describe what that is because it's going to be important for the results. So people got an all or none, 1 or 0, for the following events if they occurred: follicular pooling, piriform pooling, laryngeal penetration from the vallecula, or laryngeal penetration from the piriform. They also got a point for every time they aspirated, so that was variable. And we also scored whether or not they had complete esophageal clearance. So if everything went clear through the esophagus, they got a score of 0. If none of it did, then a score of 3. So as you can probably tell, similar to the penetration aspiration scale, a higher score equals a less safe swallow. So now, what did we find in the study? Hopefully you're super excited to hear. First, let me describe who our patients were. Patient characteristics involved people with severe dysphagia. Many had PEG tube feedings. There's much more detail in Table 1 of the paper. Hopefully many of you guys read the paper before, because that's sort of the goal of Dysphagia Grand Rounds. You read the paper before I explain it, maybe you read it again. But back to this, recurrent pneumonias, and that they were unable to swallow their own saliva. Many of them were actually spitting in a cup, okay? So they were pretty severe patients. So just to remind you, our at-rest hypothesis was as follows. With maximal levels of stimulation at rest, the hyoid bone would descend and move posteriorly, and the larynx would descend as well. So what we found was significant lowering of the hyoid bone. The larynx did not have significant change in position. So here's what it looked like. We have that on-off on period that I talked about before. Now, when stimulation was on, just before it came off, the hyoid was low. But when stimulation was turned off, the hyoid raised back up, and then when it was back on, the hyoid went right back down. So what we found is that surface electrical stimulation on the anterior neck causes significant descent of the hyoid bone. Okay, and so we saw that same trend that we anticipated of low, high, low. Now, what were our results during swallowing? We expected, now keeping in mind during swallowing that we anticipate lower hyoid peaks would be achieved during stimulation, and that's exactly what we saw. So let me see if I can get my mouse over here for you guys. Okay, there it is. So this graph, which I'll show you, on the y-axis, we're basically showing the change in height of the hyoid bone. Each line represents a patient, and this is hyoid movement. So this is the off period, and this is the on period, okay? So when they were swallowing with no stimulation, their peaks were higher than when they were swallowing with stimulation. So that's what this graph is showing, that there was lower hyoid peaks achieved with the stimulation, okay? Now, our other hypothesis is that swallowing would improve with sensory stimulation. And what did we find? So let me orient you to this graph again. So what you're seeing on the y-axis is the penetration aspiration scale, which really goes from 1 to 8, but this scale is not perfect. Essentially, up in this area is increased aspiration, and this area is decreased aspiration. Each line represents a patient for their no stimulated swallows to their sensory stimulated swallows. And what you can see, there's no clear trend here. It's not, we're not clearly seeing that all patients have an increase or a decrease. And that is shown in this p-value here, where there's no difference with penetration aspiration scale. However, with the NIH swallowing safety scale, what we find is that most patients have a downward trend in their score. Recall now that a higher score on the NIH swallowing safety scale indicates less safe swallowing. And we find when people swallowed with sensory stimulation compared to their swallows with no sensory stimulation, again, that's that low level of stimulation, they tended to have safer swallowing. Okay, so now our final, well, one of our final hypotheses was that swallowing would worsen with the motor stimulation. So now this is the stimulation where we are actually stimulating muscles in the anterior neck because they had a higher level of amplitude. And what we find is the following, that there was no difference with the penetration aspiration scale. Again, you're seeing that each line represents a patient, and there's no clear trend in upward movement of these lines or downward. If they were upward movements, it would mean that swallowing worsened. Downward would mean that swallowing improved and was less safe, was more safe. Similarly, with the NIH swallowing safety scale, there was also no difference with motor stimulation. So motor stimulation did not worsen swallowing. Sensory stimulation improved swallowing. So I want to go over this interesting relationship that we found, because this is really, in my opinion, where the best part of the paper is. So this is looking at the relationship between hyoid movement at rest and swallowing severity scores. Our question was, is there a relationship between the amount of hyoid descent that a patient has and the extent to which they improve or worsen with swallowing and stimulation? Okay, so I'm going to read this to you, and I promise to explain it. Improvement in the penetration aspiration scale during motor stimulation was significantly inversely related to the degree to which the hyoid bone was depressed during motor levels of stimulation at rest. The relationship demonstrated that those with the greatest hyoid depression at rest had the greatest reduction on the penetration aspiration scale during motor levels of stimulation while swallowing. So let me just explain that to you. This graph, I think, does a good job of explaining that. Again, any data up here indicates that there is decreased aspiration. Data down here indicates that there is increased aspiration. Along this axis, what we're seeing is change in hyoid position at rest. So people who had a whole lot of descent at rest with stimulation on also had decreases in aspiration. Okay, that's what this correlation is showing. People who had very little change with stimulation at rest, when they swallowed with that same stimulation level, had an increase in aspiration. Okay, so what does all of this mean? Well, one important finding is that we find hyoid descent, and this refutes the claims of significant hyolaryngeal elevation within the first or any e-stim therapeutic session, which is what is trained in the Vital Stim course that we went to in the manual. Does this mean that e-stim is bad for dysphagia? No. What I believe is that something interesting is happening, but perhaps not where we're looking. Okay? So, why did we find this inverse relationship, which is that people who had the most descent of the hyoid bone with motor stimulation, using that same stimulation during a swallow, had decreases in aspiration? It appears as though we're actually perturbing them. And actually, that's probably what works. So let me read this quote from the paper. Perhaps those patients who felt a greater downward pull on the hyoid when stimulation was turned on at maximal levels made a greater effort to elevate the hyolaryngeal complex when swallowing in an attempt to overcome the effects of the stimulation. Okay, so again, something interesting is happening, but perhaps not where we're looking. So this brings me in mind of the concept of challenge. In order for this person to go from a wheelchair to walking freely, this person has got to have less and less support, walking support. And I'm sure that that can be difficult. Now, in the PT world, challenge is part of the rehab game. It just is something you have to do to get better. Now, I know that challenge is easier in PT than SLP because they have safety mechanisms that we do not. This child here has a harness. So in the event that she falls, or she won't fall. So if her legs give out on her, there's something to hold her up. What we don't have are little nets that we can put over the larynx to catch the bolus if the challenge doesn't go so well, right? So we do have to remember that patients in the study were very severe though. And we pulled their larynx down, their hyoid down to the maximum extent, and they actually improved. So what does this mean for us in terms of dysphagia rehab? Well, two main categories we must always remember is that one thing that we can do in rehab is challenge the impairment. And the goal there is to restore function. Think of the walking. This person has issues with locomotion. We're challenging their impairment in locomotion by making it harder so they learn to overcome the difficulty. And our goal is to restore function so they can walk freely. Another goal of rehab is to reduce the impairment with compensatory mechanisms, only to minimize the effect of the disability when we know we can't actually restore function. So the concern I have is that in fields such as occupational and physical therapy, as you can see here, this gentleman has what's called constraint-induced movement therapy. And that means they tie back the good arm to force the bad arm to work. But unfortunately, quite a bit in the field of speech pathology, as it relates to swallowing, we often tie back the bad arm to force the good arm to work. So electrical stimulation, in my opinion, offers a unique opportunity to induce greater effort and perhaps awareness to swallowing sometimes at the same time. So the greater effort can be induced by having someone overcome the effects of the motor stimulation if you stimulate on the anterior neck where the larynx and hyoid can be pulled down, as well as greater awareness, which is the effects of sensory stimulation, okay? So an important finding is that improvements with sensory stimulation, you got to embrace a tingle, okay? As people start to feel more aware of swallowing, like with a sour bolus or a cold bolus, it's possible that that heightened awareness is actually a helpful thing. How does this work? Well, more sensory information in some part of the body leads to messages to the brainstem to plan a more robust swallow response. It's already been shown that if you increased oral sensation, such as with a large bolus, you can end up with a more robust early pharyngeal response. So this concept has been very well understood as it relates to oral situations like with a sour bolus or a cold bolus, but it's possible that e-stim allows this with the prickly sensation on the neck. So the improvement on the NIH swallowing safety scale tended to be related to higher initial scores. So the more severely affected patients were the ones who had the greatest improvement with the sensory stimulation. Now, overall, this to me shows that an important finding is also not just the fact that we can present a challenge for them to overcome, but in patients maybe who might be too severe, sensory stimulation, while it's neglected, untrained, forgotten, and confusing, might be critical. However, we do have to remember that the motor level still has that sensory experience. You're not choosing motor or sensory, it's sensory only or sensory motor. So when you're giving somebody the motor level stimulation, you are also providing sensory stimulation. Sensory stimulation does come with potential risks, of course, and that is habituation. These are sour candies. I'm sure you've had a bag of sour candies and the first one was really super sour, and after a while they didn't taste as sour as they could have. So it's possible that with a sensory stimulation there might be some habituation that we might need to consider as well. So essentially, the introduction to e-stim and dysphagia rehab, we have to remember physiology matters. It's still a relatively new rehabilitation technique compared to others, and you have to remember that you can manipulate somebody's airway with electrical stimulation. Why does this matter? Because when I've given several talks, I think I've been giving e-stim talks for 13 or 14 years now, and whenever I say, hey, how many of you guys use e-stim? maybe 50% say yes. And I say, great, so we can fly through this anatomy and physiology because you've had the training and you understand it. And typically when I ask about muscles, I get pin drop silence. In fact, I think I should precede those questions with, brace yourselves, awkward silence is coming, because oftentimes people are not quite as aware of how the muscles work, even though they're actually manipulating them. So it's really important that we pay attention to that. And I'm going to end with this last point before we move on to Rinki's section, and that in the eStim training courses, in this particular paper, here's a quote where we say this electrode array was recommended as effective during certification training of the first 2 authors. What we're saying here is that 2 authors from this paper, Dr. Ludlow and myself, went to the training prior to doing the study so we could understand the training and how to use the device. But what we found is that in this training, a lot of people were not asking the questions we were asking. So when they said it's going to elevate the larynx, we were waiting for everyone to go, wait, that's not possible. These muscles actually pull the larynx down. So what we want for our field to do is be more knowledgeable and let us do the vetting. So we should be saying, actually, this is the best way that this device could work because I'm an expert in swallowing and I'm the one who's going to have to manipulate somebody's airway. And in the future, perhaps we should be going to these trainings with this shirt, Heckler's Gonna Heckle, because we should be going there as a force saying, hey, I know I'm an expert in swallowing physiology, and you're not going to tell me the opposite of what these muscles do, okay? So to finalize, there are ways that you can increase your knowledge. I strongly encourage my students to get the Swallowing Pocket Guide. I have a free podcast called Down the Hatch where we learn about eStim and other things. And the hope is in the science site, which has recently launched. We have a course called Application of Electrical Stimulation in Dysphagia Management. And so there are a number of resources out there where you can learn, in addition to Dysphagia Grand Rounds, a more manufacturer-less training. So it's more about, these are the principles you need to know. We're not selling you a device. We're saying go into any training, any certification with this knowledge in your head so you can ask critical questions about the device that you might purchase. Okay. Final limitations are that we had a small sample size, we had heterogeneous patients, and we only looked at the immediate effects, so we don't actually know how the long-term effects of this eStim might work in this patient population. And now we're going to move on to clinical implications with Rinki.
Hi.
Hey.
Can everyone hear me okay?
I can hear you just fine.
Okay. I am just going to get started. Okay, so we're going to talk about the clinical implications of the uses of eStim in dysphagia management today, which basically means, what does this mean for us, the everyday clinician? And before I start, I just want to say what an honor it is for me as a clinician to be collaborating with an expert swallowing researcher like Dr. Humbert in Dysphagia Grand Rounds. And we really thank the National Foundation of Swallowing Disorders for giving us this platform to discuss this with clinicians and hopefully get the message out there that we just need to be more aware of what the evidence is telling us before we apply treatment modalities that are marketed to us and improve patient outcomes without a proper understanding of how that's affecting our patient's physiology. So just a quick background, I'm a speech-language pathologist from Mumbai, India. As Ed said, I did my master's at UT Dallas and I graduated in 2011. And I did my CFY. I saw, and this, you guys might resonate with this as well, I saw my supervisor using this neat device, strapping on electrodes on patients' necks, and their diets were improving, and everybody was talking about how great this device was. My facilities was advertising it as something that set us apart from others. And just like anybody else wanting to be the best clinician I could be, I thought I need to get my vital stim certification. And so the same year that I got my CCC from ASHA, I was also a vital stim certified dysphagia clinician. And this is not just about vital stim. I just haven't done the AmpCare or the Guardian training or eSwallow, but what these training manuals tell us, and specifically what vital stim told us in the training, was that combining vital stim with traditional swallowing therapy will help accelerate strengthening, restore function, and help the brain remap the swallow. And for a new clinician, that just sounded very fascinating and something I really couldn't wait to learn and start using with my patients. The manual told us that it caused significant laryngeal elevation, and as Dr. Humbert said, this was expected in the first eStim session in many patients. It contributed significantly to the improvement in swallow function. And this is even on their website even now, where they say that it's probably most useful for mild to moderate dysphagia patients who benefit the most, with over 80% discontinuing PEG tubes. And that's our ultimate goal. We don't want our patients to be NPO. We want to advance them to a PO diet and improve their quality of life. So all this sounded really interesting, and this is from the Vital Stim Training Manual, where they gave us this neat cheat sheet, and they said, these are what the muscles of swallow, this is what the different muscles of swallowing does. These are the possible signs and symptoms that we can see at bedside, and these are the different electrode placements we should use and start using eStim 60 minutes a day, 5 times a week to improve a patient's swallowing. So for example, if I wanted to improve higher laryngeal elevation, I knew that strapping on the electrodes in a certain position would help me achieve that. So why are we even talking about eStim, and what is this whole fuss about eStim? Well, eStim is among the most studied swallowing interventions in dysphagia literature. However, we have some questions that are unanswered. We have conflicting results regarding eStim benefits, risks, efficacy. We don't know what parameters need to be used. Should we be using sensory only, sensory and motor? Which patients do we need to use this with? What is the efficacy in patients with stroke versus Parkinson's? What placements would be the best? And all these questions are unanswered about eStim. And eStim is something that allows us to manipulate someone's physiology. So how we're applying this with our patients really matters, because we can potentially, we could be doing more harm than good. One of the surveys done showed that clinicians, and this was back in 2007, clinicians continue to use eStim as one of the most commonly used treatment modalities in dysphagia intervention. Also, another thing that was interesting to learn as I've grown into the field as a clinician is that when we graduate, industry partners know that we probably don't have adequate training in dysphagia, and yet we are providing over 90% of dysphagia services across all the different healthcare settings that we work in, and this has been shown in ASHA surveys. So obviously we want to do what's best for our patients, but then this has probably being looked as a lucrative opportunity for partners in industry. Dr. Logeman said that Vital Stim might give some clinicians an easy out, where we feel like even if we don't have an actual understanding of what the physiological impairment is or how physiology even works for swallowing, we have this device that we can use that does something to the patients, that's showing improvements, everyone's talking about it. There's anecdotal evidence that it works. So we can prove our value and we can show that we're really making a difference. And also clinicians who are using it, in another survey, this was shown that they continue to have a lot of misconceptions regarding the perceived effects and benefits of eStim in swallowing. So it's important for us to understand that the question shouldn't be to eStim or not to eStim. And Dr. Humbert said that. The question should be, how is eStim affecting my patient's physiology? It's not a one-stop, one-size-fits-all cure for every kind of dysphagia across all levels of severity, across all the different patients. It has to be used in a very individualized way. And just like you use the chin tuck or you would use the Masako, the eStim is just another tool in our toolbox that we need to figure out how it would affect our individual patient's physiology and how it would help us improve their outcomes in therapy. So the biggest takeaways for me from this particular study, and it's funny because I had read through all the literature that was presented to me in the Vital Stim training, and I'm sure the other trainings present clinicians with literature as well. And they spoke about almost every study out there and kind of highlighted why e-stim works and what the improvements and outcomes were. But they didn't mention this particular study. And that's okay. They don't have to tell us that a particular study found that the hyoid was actually descending when one of their biggest claims is that e-stim causes the hyoid to elevate. But it is up to us as clinicians to properly vet these devices and to go out and read what the evidence is telling us before we're applying a treatment modality to our patients. I don't think I would have not used e-stim if I was told. There was this one particular study that found that the hyoid was descending because, like Dr. Humbert said, we're just not looking at what that means. We would just look at it in a different way and see how we could use that to improve our patient's physiology. So the biggest takeaway for me from this study was that the only appreciable motor effects of surface e-stim was to cause the hyoid to descend. So it actually produced movement in the opposite direction as to what we expect e-stim would do, which is cause the hyoid to elevate, which is required for safe swallowing. So what does that mean? Essentially, it refutes the claims that significant hyolaryngeal elevation will be achieved within the first or any e-stim therapeutic session with this particular electrode placement, that is 3B, because the researchers found that the hyoid was actually descending in these patients. But that is not necessarily bad, because they also found that the patients with the greatest hyoid depression during motor levels of stimulation at rest had the greatest improvement in their swallowing severity scores at those levels of stimulation. So what that means to me as a clinician, and the premise of that is that when that stimulation was applied and the hyoid was actually being depressed, it served as something like a challenge or a resistance that patients then had to work extra hard to overcome. So placing the electrodes weren't just pushing the hyoid and elevating it by themselves, but the patients were actually having to work extra hard to overcome that resistance, which was then translating into that improvement in their swallowing scores. So that's something that we could use actively, just as we use other lingual resistance exercises and other resistance exercises in our therapy. I could use this potentially with someone if I've seen them in fluoro with their electrodes on, and I've seen that they have some capability of elevating the hyoid and working hard to overcome that resistance. It's something I could potentially use to challenge their swallow and help improve that hyolaryngeal elevation over time. Another important thing that I took away from this is that there might be some patients who just are so severely impaired that they cannot elevate their hyoid bone at all. So no matter how much, even at the lowest level of resistance, perhaps they can do nothing to overcome that challenge. So what we're doing by potentially placing electrodes and turning the e-stim on in these patients, if we've not watched that happen under imaging, if they're silently aspirating, we're potentially pulling their larynx down, having them do exercises and different PO trials, and we're essentially increasing the risk for aspiration. So this was a really interesting thing for me to now keep in mind before I use e-stim with my patients and I'm trying to improve hyolaryngeal elevation. The other big takeaway was that sensory stimulation can have therapeutic benefits. So I remember in my vital stim training manual, and I'm not sure how the other trainings present this information, we were told that the sensory only level has no therapeutic benefits. So you would start with the sensory, gradually increase the level of current being delivered, ask the patient when they feel that tugging or pulling sensation, which is the motor level of stimulation. And that's when e-stim would do what it's supposed to be doing, and that is alter the swallowing physiology. So it was very interesting when this paper in particular, and there are several studies that you can look up, and they found that sensory only stimulation reduced the instances of penetration and aspiration in this group. And in fact, it might be working in a way just like we use thermotactile stim, and Dr. Humbert has some other very interesting papers on sensory stimulation and how that correlates with the cortical reorganization of the brain in relation to swallow function, how it might actually be altering the motor patterns similar to what is supposed to occur with other sensory-based treatments. So really the big takeaway was, yes, there was hyoid depression, but that's not necessarily a bad thing. And using e-stim in these patients presents us with a unique opportunity to induce greater effort by overcoming that depression and overcoming the effects of the motor stimulation, and greater awareness. These were patients who had severe dysphagia for over 6 months, and the fact that any change or any awareness could be created immediately after putting that e-stim on is a huge clinical implication and has great application for us in therapy. So some of the clinicians who are more risk averse and we don't have access to imaging, especially in long-term care facilities, we know that the sensory only level is probably not going to cause enough stimulation to hold the larynx down and put someone at risk for aspiration. So we could start with this, combine that with our other exercises that we're doing in therapy, and hopefully help improve this awareness of swallowing and help improve their swallow function. So as clinicians, we really need to be aware of what the evidence is telling us. This was just one paper we discussed because that's the premise of Dysphagia Grand Rounds. We release one paper every month on a topic that we think is important for clinicians, which is open access. And we have clinicians read it. I read it just as you would. Then we would watch Dr. Humbert discuss the paper and then probably go back and see if our understanding of the research has changed and try to improve our ability to appraise the literature and then learn what we can from it to apply it to our practice. So Dr. Humbert and colleagues also have another open access paper. We've made that available in the PDF references today. It's called Electrical Stimulation and Swallowing. How much do we know? So basically, it presents an overview of not just swallowing anatomy and physiology, but an overview of all the values or the benefits and the limitations of what the research literature tells us about swallowing, and really reiterates and drives home that fact that we don't need to be thinking about should I e-stim or not. We're clinicians, we're not technicians. So we shouldn't be looking at researchers to give us an answer to that question. We should be reading the evidence and the research to really understand what the physiologic impact or effects of using something like electrical stimulation is, how that affects the swallowing physiology, and then determine if that is something that we can use with the patient in front of us, tying that in with their physiological impairments. And that's been something that has been a great learning experience for me in these couple of months doing Dysphagia Grand Rounds as well. So like I said, the right question is not asking to e-stim or not to e-stim. Dr. Humbert has this very interesting analogy that she does where she says it's like someone going to an MD and saying, should I be using Tylenol or not? And then the doctor's question would be, for what? Do you have fractured ribs? Do you have gastritis? Do you have a headache? It's not something that can be universally used with all our patients. We should be using it. The question is just how, with whom, and why we should be using it, not whether we should be using it or not. It's important for us as clinicians to review the current evidence, like I said. Improving our understanding of anatomy and physiology cannot be overstated. That's just something we need to be doing. We need to know what these muscles that we're manipulating even does with respect to how it controls movements of the larynx, the hyoid, the pharynx. You know, go back. It's something we can learn, and it's something that we owe to our patients as clinicians to have a thorough understanding of if we're calling ourselves swallowing experts in different healthcare settings. If we have access to imaging, we should be assessing the physiological effects of e-stim, just as we would to see if a chin tuck worked in a patient or a supraglottic swallow is helpful, or we're doing PO trials of these different consistencies. We can leave the electrodes on in the fluoro suite, see what it does at rest, see what it does with a dry swallow, see what it does with different bolus consistencies to see if it's even something we should be using in our clinical practice. Dr. Humbert always states this, and I've started doing that more and more now, and it's so critical for all of us to do because we have access to this huge patient population that we see every day. But yet, it is surprising that most of us cannot really explain why we're doing what we're doing. Even if we don't have access to imaging, why are we using the effortful swallow? Why are we doing lingual resistance exercises for someone who probably has an impaired UES opening? We have to learn to tie in our therapy with the physiological impairments and just be able to explain confidently why we're doing what we're doing. So if we're using e-stim and a family member asks me, can you please show me how this has worked for you and why it's worked? if I've collected data on my patients and documented those trends, I would be able to confidently state why my facility should be paying to train other clinicians and why they should be purchasing this device for me. And this is something I always stress in any talk that I give, one size does not fit all. I don't know why, even when I was trained in grad school and more as clinicians, we are looking for just quick fixes. We're looking for an algorithm. We're looking for this cheat sheet that tells us what to do with all our patients with dysphagia. But that's not how any other medical professional thinks. If your cardiologist or your neurologist use the same treatment, or even scarier would be if a surgeon did the same surgery with everybody who went to them, I don't know how that practice or that profession would survive. And that's kind of where we're at in dysphagia management. And I've been guilty of this too, but I think interacting with researchers like Dr. Humbert and so many other researchers who presented Dysphagia Research Society, I've just learned to think more critically, and I think that's the missing piece that would really help us push our profession forward and prove why we are truly swallowing experts and not just technicians who could strap on electrodes and help improve someone's swallowing. Also, I cannot stress this enough, researchers are our friends. There's nothing to be intimidated or afraid of when approaching researchers. They want access to the patients we have. We want access to the methods or the design of the methodology they have, so we can work together and do what's best for our patients and improve patient outcomes, which is kind of why we started Dysphagia Grand Rounds. It was just a clinician coming together with a researcher and thinking, how can we make this how can we make research fun, and how can we encourage clinicians to read one paper a month, see what's out there, see what the evidence is telling us, learn to understand and dig deeper into research beyond those confusing statistics and the Bonferroni and what is statistically significant and p-values and t-tests. What is the underlying message that we can take home and apply to our clinical practice? So the primary goal is to encourage clinicians to become better consumers of dysphagia research literature and empower them with the tools they need to apply research evidence to clinical practice with greater confidence and critical thinking. If you go on the website www.dysphagiagrandrounds.com, we have a free webinar called Research Methods 101, which Dr. Humbert has recorded. I think it's around 30 minutes. It's like a crash course for clinicians that helps you understand the different things that will be the different terminologies or the different statistical measures that come up in these different papers that might help you. It would be helpful to review that before you start watching other webinars or reading other papers, and it's free. So feel free to explore that. And like Ed mentioned, we don't have CEUs for this particular talk. We wanted it to be free. And then for those of you who want CEUs, you can purchase the Asher DGR bundle, which is also on the website, and then you can get CEUs for watching all these Dysphagia Grand Rounds. So the three important principles that guide evidence-based practice are the clinical expertise, the best research evidence, and the patient's values, preferences, and needs. And this is from the Asher website. But I think what seems to be missing and is such an important part of this triangle is actually a fourth point, and that is critical thinking. We just have to learn how to analyze and appraise the evidence better. There is research being done on so many different treatment modalities, helping us understand the effects on the physiology of swallowing. So it's not just enough for us to go to a training, get certified, run after all these different certifications when we don't even know what our own practice trends are and how that modality is affecting treatments. I can't stress that enough. We just have to work harder to advocate and think more critically for our field to advance. I hope that we could answer your question, which is not to e-stim or not to e-stim, but to help you understand that that's not really the question at all. We hope what you took away from this was a better understanding of the immediate effects of e-stim on the physiology of swallowing, how it's helping stimulate these different muscles. Go home, think about the patients you're working with, how you could use e-stim at a sensory only or a sensory and motor level to help improve their swallowing. And hopefully this will give you a better understanding of the fact that researchers are our friends, and we really should be looking towards evidence to add to our own personal anecdotal evidence before using something that's so potentially powerful like eStim with our patients. So thank you so much for taking time out to watch this webinar today, and we're happy to answer any questions that you might have.
Can you hear me?
Yes.
Can everybody? Okay, there are two questions I see that I can start to answer. One is by Priyanka, and her question is, please explain the rationale for using sensory stimulation as an interventional target in improving swallowing physiology. And to answer your question, it's no different from any other sensory modality. So there is thermal tactile stimulation, there's a sour bolus, there is a cold bolus. Anything you might do to heighten sensory awareness is what the category of sensory level electrical stimulation is. Again, it depends on what you want to do. Maybe you're targeting a specific anatomy, such as the fascial arches, because you want to speed up swallow onset, which is the thermal tactile stimulation, versus just generally getting someone to attend to the task better. Of course, with all of these, you run the risk of habituation and that the sensation doesn't feel the same as you continue, but it is important that we understand that these are basically the same. I have another question here from Lisa Hess, and it says, I was trained with the Guardian Way, which teaches only submental placement. Patients I treated that had previously been treated with VitalStim noticed a distinct difference. Their swallow improved with the Guardian Way because it targets only muscles that affect hyoid elevation. Please comment. So I am familiar with Guardian, I'm familiar with AmpCare, that's also submental only, and VitalStim. And I can talk about what the literature says, and I can talk about, but I can't speak to why patients had success, because obviously these are your patients and we all just define success differently. But the literature shows that there is, in terms of rehabilitation, overall, both modalities don't have the best studies dedicated to them. But with submental, you're targeting the agonists, meaning the muscles that are needed to do the task. You're targeting hyoid elevators. So if you feel that you need to help somebody to get better hyoid elevation, then perhaps that's why it's working, because that could be what their impairment is. If you want to challenge a swallow, the jury is still out as to whether or not submental stimulation can challenge a swallow, because it's targeting the muscles that help you, not the muscles that make things harder for you. So right now that's where we are with our understanding there. So I have a question that says, can you go over billing? I might need to move past that one for now. Maybe Rinki, you can think about that one.
Mm-hmm.
What the other question I have is, what about eStim in dysphagia due to head and neck cancer? A big trial by Langmore et al. Reported to not very significant. Right, so what's interesting is there's clinical significance and there is statistical significance. And in the freebie that Rinki was talking about, we go over the concept that you can have statistical significance, which is a p-value of less than 5, but the clinical relevance might not be high. And then also in the most recent Dysphagia Grand Rounds, we talk about EMSD and the idea of penetration aspiration scores and what it means when you average them. The reason I'm saying that is because my understanding of the Langmore study is that there was statistically significant improvement in the penetration aspiration score, but it went from like a 4-point-something to a 5-point-something. Don't quote me on that. And it's not quite clear what that actually means. So a couple of things could happen. One is my understanding that they used the Guardian Way and they targeted the submental muscles. And these are people who have fibrosis. So you're targeting the agonists and you're targeting people who may not have achieved the same amount of contraction because they have such fibrosis. So it's possible that it was a patient selection issue, and perhaps it could have been a an anatomical target location. We won't know until another study occurs where that is being tested. Another question by Emma. is what are the effects of eStim if you change the placement of the electrodes? Has this been explored? Yes, it has. My dissertation was in healthy people, and we had 10 different placements. This is also free on PubMed Central. If you type in Humbert I believe this study was published in 2006. And what we did is we had placements that were above and below the highway bone, some both above and below the highway bone. Overall, our finding was that any placement where an electrode was below the highway bone, even if there was an electrode also above the highway bone, there was significant hyolaryngeal descent. The placements that had submental only did not have significant anterior movement, but since my study, there have been other studies that have showed some significant anterior movement at rest with submental only placements. And we also did this to look at vocal fold function, and vocal fold function did not happen at all. Okay, Megan, have there been studies showing lasting effects on swallowing after stimulation is removed? So this is often the caveat in research, and this is where the responsibility is on me, okay, as a researcher. So a lot of the long-term studies do not have outcome variables that are physiologic. They don't say this is why this person aspirated, this is the physiology, the pathophysiology, and we're following the pathophysiology for several weeks after training. Oh, and by the way, it proved. They're often diet change outcomes, which is highly subjective, or there are penetration aspiration changes, which we don't understand why they aspirated. So you could find the penetration aspiration scale improve significantly, but what if it's because of the UES versus the tongue versus the pharynx versus the larynx? We still haven't pinpointed what electrical stimulation is better at targeting versus not so good at targeting. So unfortunately, the answer right now is the lasting effect studies, sure, they're out there, but they're not strong studies.
Can I jump in here?
Jump in.
I would say if we're probably using sensory only, and like you mentioned, habituation is probably more likely to happen if we're using sensory only, right? So we could expect these effects not to last as long versus using sensory and motor. Would that be accurate?
Yeah, you know, it's possible, again, until we have a study where we have true objective physiologic outcomes, we'll never actually know. Elizabeth, how do you structure the goals, improving specific muscle function or ability to swallow specific textures? I think you're talking about therapy goals. If you are talking about therapy goals, and Rinki, if you can think of another type of goal that she might be referring to, with regard to goals, it's no different from any other treatment. You're using a pathophysiology that you want to target. So for instance, with an IOP, hopefully you're targeting lingual strength, because that's one thing that the IOP is known to do. With electrical stimulation, if you're saying they have reduced hyolaryngeal elevation, and I want to challenge that and target them using more effort to swallow in these muscles specifically, as opposed to an effortful swallow where God only knows what they're actually doing, and I'm going to force them to swallow against the resistance that I provide on the anterior neck, then that is your goal, for them to swallow with resistance that you hopefully will increase over time, similar to any other strength training paradigm, with the idea that they will learn to swallow with greater effort and maybe even have more muscle fibers associated with that, perhaps similar to an 8-week training with EMST or with IOP. So your goal should always be, what is the impairment I want to target? Why does this treatment target it? And how long do I think it will take, or what's the dosage? It's really not different from hopefully anything else you're doing that has a physiologic rationale.
May I jump in again?
Jump in.
Yeah, so in very few settings, our goal will anyway say, I want to improve hyolaryngeal elevation, because your goals will mostly be diet-based. And so you would say, I would want to advance my patient from nectar thick to thin liquids. And then if you're writing short-term goals about hyolaryngeal elevation, you don't specifically even have to say using NMES, because you would hopefully be using other, combining that with other exercises or strategies that you would be using in your therapy. So the thing is that Medicare now has sent out this this blast like 2 years ago, where they say that you cannot bill for a patient, coming back to billing, if you're using eStim only. So yeah, you wouldn't even put that in your goals. It's just something you would be using in addition to everything else you're doing to help improve that particular physiological function. So,
right. And so I'm glad you said that. I'm glad you said that because there is a desire to get a billing code just for e-stim, similar to physical therapy where they have a billing code dedicated to it. And there could be great utility in something like that, but it still doesn't change how we approach our goals. And I understand what you're saying, Rinki, about it being diet-based, but ultimately, when things are diet-based, but the diet isn't based on any physiological...
Yeah, we have to tie it in. Yeah,
absolutely.
I think clinicians were just strapping it on. It was, I think, whenever this came out, they found that there's contradictory evidence, and I've seen this myself where it was just being placed on 3 patients at one time in a rehab gym, sitting for 60 minutes, not doing anything else. And then that's not really skilled therapy because that's what they were being billed for. And that's why this message was sent out by Medicare saying that it cannot be used as a standalone treatment. But I wish if we start using it better and showing more objective outcomes, like you said, we can change that and hopefully have a treatment code just for e-stim.
Well, I'm a little less familiar with the history there, but I do know that I don't think any training says that you just put it on and walk off. They are all in conjunction with with standard treatment, some kind of treatment modality that you're already doing for sure. Okay, Nanette Crawford. I'm not sure how one can tell if the patient is actually using greater effort to overcome high weight descent. How does a clinician evaluate this during a therapy session? Well, unfortunately, effort is one of those things where unless you're at the gym grunting, then it's really hard for someone to know, right? But if you've ever used electrical stimulation, Nanette, and I have been at several trainings in the critical thinking and dysphagia management course that we do, we have a whole workshop just on e-stim, and the speech pathologists get to try on e-stim. And if you've ever had e-stim on your anterior neck, I've not heard anyone say, oh yeah, that was a breeze, that was just like before. They've all said it was hard to swallow against that resistance. So in the event that your patient is as strong as you or weaker, it's possible that they do require greater effort. And you can ask them if they're cognitively intact. All right, Amelia Bergman. And Elizabeth and Ed, let us know how long we should go. It's up to you. I'm happy to answer these questions. What about patients who are NPO and little to no swallows are being initiated? Many are not yet appropriate for modified Bering swallow study. Well, if they're not appropriate for modified Bering swallow study and you don't know what the problem is, then I'm not sure what treatment you would do anyway, to be honest. Like if I'm going to be a purist here and say, and I do know that you do have to go to their bedside and you do have to see them, and sometimes they're not appropriate. But maybe e-stim is not the best thing to start with if you're not sure how you want to manipulate somebody's airway that you have not yet seen the function of. So maybe there are other things you could do, lemon swab. I mean, I'm not sure what that would be because obviously it depends on the patients you're dealing with. But keep in mind in this particular study, these were patients who were spitting in a cup. They had PEG tubes. Many of them could barely initiate a swallow. And we did find, granted, we did have video fluoroscopy, which is, I understand you're saying you don't have. But in the event that you can go down to fluoro, I always strongly recommend that you bring electrical stimulation with you so you can see what it's doing to somebody's airway, 1, and 2, do they have the capacity to... Okay, so let's move to Casey. It is dangerous to use...
I think you're back now. You just went away for a minute.
Okay. Okay. It is dangerous to use motor stimulation then on patients who we are not 100% certain have the significant enough depression to cause the challenge, and it's beneficial since the study showed those who did not have a significant of a highway depression actually had increased penetration aspiration risk. No, what we're showing is that actually the patients who had the most descent with high weight had the best outcomes. We challenged them, and what they did is they felt that there was an error they needed to correct and swallowed more robustly. So what that means is that this is actually the inverse thing. We would think that challenging people who are on a PEG tube can't even swallow their own saliva and are just struggling to swallow anything if you pull their hyoid down the most, that they would actually have the most errors. And in this study, there was an inverse relationship. They actually did better. So if imaging isn't available, oh, okay. Would you recommend?
I was waiting for that question.
Okay.
What do we do when we can't see the swallow?
Yeah, okay, so Nanette has come back. How does one know if one is truly a good candidate for eStim? Great question, Nanette. And is eStim contraindicated in certain patient populations that you know of, such as ALS, or is that patient specific as well? Everything is patient specific. Everything is patient specific. It's what Rinki was saying. You are always doing a study, a research study with your patients that's an N of 1. And that means you're saying, this patient in front of me has these specific needs, and I'm going to tailor my treatment to them. So overall, I would say if you have a patient who is having issues with perhaps attendance to the swallow, or could benefit somehow from sensory stimulation, possible that sensory-only stimulation. However, there may also be people who have issues with hyolaryngeal function, and you know with electrical stimulation you're definitely targeting hyolaryngeal function. There's a paper by Park in 2009 that shows that people who train effortful swallows with neck stimulation that pulls the larynx down for 2 weeks had higher hyoid elevation compared to those who just did effortful swallows. So if you want to attempt a more resistance training type paradigm, that might be a good example of a patient who would be a better candidate for it, versus somebody like, I don't know, with like velar nasal regurgitation because of velar issues, for instance. Elise Frazier, can there be any research of effects of eStim with facial placement? I don't know if there's research on it, but I know that almost all the devices actually recommend that you consider a facial placement. And then I'll take this last question. Can you speak to your opinion on the use of SEMG concurrently with NMES in dysphagia therapy? So yes, briefly, I know that there are 2 devices for sure. There's an MP device and the Guardian device that have a concurrent sort of an EMG incorporated in it. And the idea is that when you get a certain amount of muscle activation, the eStim picks up. And the paper by Leela Manett in 2002 discusses this whole synchrony idea. So what I would say is that it might be a good way for you to train them to get a certain amount of muscle contraction before you actually apply electrical stimulation. But unfortunately, the study that I'm referring to did not have good controls. It wasn't the strongest study. So the jury is still kind of out on the incorporation of SEMG and surface electrical stimulation.
Let me ask a question that came to my mind as you were talking, and that was whether you see a time in the near future where there is personalized characteristics that would point someone toward the use of stim versus not stim.
So are you asking if there is will there be a time where there's sort of a profile that one can create, a swallowing profile? Yes. Unfortunately, the thing is, that time is here. You know why we don't have that information? Because all the studies, including ours, I'm willing to raise my hand, and in my limitations, I do say we did not characterize a swallow. What we need to do in our studies, all the studies that have already collected data with video fluoroscopy, we can all go back to them and say, what was the underlying swallowing pathophysiology that these people had, and which ones improved and which ones didn't. The only problem is that we're not analyzing our data the right way. It doesn't have to be this big new fancy device that needs to be created. We just need to spend time analyzing the data. Every single video fluoroscopic study, as long as it has enough frames per second, like 30 frames per second, the answer is right there. We just have not been trained as researchers to look at that in particular.
That seems like a natural next step.
Yes, absolutely. And one that can be attained.
I see a time in the near future where we'll be looking back and telling junior clinicians, can you believe we were treating things without having access to fees or MBSs? I see more and more clinicians are advocating for this because we now realize how important it is to understand what the underlying pathophysiology is. And I hope and foresee a time where, you know, it'll just be something that's integrated in our everyday practice.
Absolutely.
So I'd like to wrap up, but I want to thank both of you for a stimulating conversation tonight. We didn't get through all the questions, so that means people were interested.
I hope so.
Yes, so that's a good thing. So I'd like to thank both of you for taking the time out tonight to share your knowledge and viewpoint with all of us.
Thanks for having us.
You're welcome. Elizabeth, could you put up my last slide? I just want to go over a few items. I want to thank everybody for attending this evening. And there will be a one-page, 3-minute survey that comes out in an email to you within the next 30 to 60 minutes. We'd appreciate it if you could fill that out. It helps guide us in our future direction. And if you did have a question that wasn't answered, please email us at info@nfoc.com, and we'll get that to Dr. Humbert or Rinki and track down an answer for you. We hope you join us in June for National Dysphagia Awareness Month and for future webinars. I want to thank Elizabeth Daly. Was Elizabeth Lipton until recently. Congratulations, Elizabeth. And thank you for providing the support you did this evening. And with that, I think we'll sign off. And again, thank you to our speakers and to our participants. Good night, everyone.
Good night.
Bye-bye.
Thank you. Good night.
Good night.